Hi, Ludwig's angina. This is an ENT medical emergency. If we don't rush the patient to the hospital at the earliest, we may sometimes lose the patient. It's a very important topic. I'll give a small introduction so that you can understand better. See, in the neck there are so many structures and there are spaces in between each structure so that each structure can work smoothly and individually. So these spaces, in medical terms, we call it potential space because there is no space as such in between two structures. But if necessary, that space, that place between two muscles or structures can give way to accommodate the infection or mass for a given time. So we call it potential space. So we have so many potential spaces in the neck. So when we have infection in submandibular and submental region, or if I divide submandibular into two, that is sublingual and submaxillary along with submental region, these three spaces, then we call it Ludwig's angina. So I'll show you a few pictures, then I'll go ahead with the topic. This is a normal picture where all the structures are normal and you cannot see any space in between them. Here you have a patient of Ludwig's angina where there is infection. I will not say pus because there is no frank pus collection in such cases. There will be only edematous fluid collection and these two spaces which we call as a submandibular space, which is divided into sublingual below the tongue and submaxillary. Not only these two spaces, one more space which is submental. So what happens is, to start with, there will be infection of the tooth, especially the last molars. See, this is a mandible and you have a line here, mylohyoid line, and the specialty of the last 2-3 molars are that the root of the last 2-3 molars, they go beyond it lies below the level of the mylohyoid line. So what happens? The infection from the root, periodontitis, it can easily spread from that root to the submaxillary space. So this mylohyoid line, here you have a diaphragm-like muscle. So below that muscle, above you have sublingual space, below has submaxillary space. That's how it starts. So once it reaches the submaxillary space, from there it can spread to the sublingual space. Likewise, it can spread from the submaxillary space of one side to the other side. From that side submaxillary space, it can spread to the sublingual space of that particular side. Meantime, it reaches the submental space too. That's what happens. The source is not only from tooth, it can be from the tonsils or any floor of the mouth trauma, or it can be submandibular gland severe infection also. The commonest cause being dental. The cause being infection, the organisms involved are Streptococcus or Staphylococcus, Klebsiella or Anaerobes. These are the common ones. So to start with, they will say they had slight fever and they started having discomfort, especially in the upper part of the neck. They have difficulty in swallowing, so they keep the mouth open and they'll be drooling of saliva, and as the condition becomes worse, the upper neck swelling becomes painful and it increases in size, leading to breathing difficulty. So this is a video of a patient presented to our hospital in the emergency department where she presented with all these complaints. You can see the significant neck swelling, tongue pushed upwards, floor of the mouth, it's swollen up. This is one patient. This is another patient, the whole thing is swollen up, upper neck is swollen up, it's woody in induration, it is tender and the floor of the mouth is swollen up, pushing the tonsils, pushing the tongue backwards. It pushes the tongue upwards and backwards. So there will be breathing difficulty. Immediately, we went ahead and did a flexible laryngoscopy to assess how much of air obstruction is there. This is very important so that we can convey to our anesthetist that intubation is going to be difficult, or we shall go ahead, ENT shall go ahead and do a tracheostomy or cricothyroidotomy, then we'll start the surgery. So this assessment is very important. Now, if we leave the condition at this stage and the patient doesn't come to the hospital, this can lead to airway obstruction and respiratory failure. And the infection can spread from these spaces to other spaces like parapharyngeal space, retropharyngeal space, and it can track down to the mediastinum, leading to mediastinitis, pneumonia, and finally landing up in septicemia. The patient can lose life. Coming to investigations, the important investigations are CBC, ESR, C-reactive protein, and procalcitonin. The all level of all these will be raised. We need urgent CT scan with contrast, and if we find that it can be because of a dental source, the infection is from a dental cause, we'll go ahead and do a CBCT, cone beam CT scan dental 2. CT chest is X-ray chest is also very important. So the patient will be admitted in intensive care unit, will not be given anything to be taken because we plan for surgery. Oxygen inhalation will be going on along with IV antibiotics, IV steroids, and IV fluids. We'll take consent for tracheostomy and cricothyroidotomy, explaining that we need to do decompression of the neck swelling. Now, coming to surgery, coming to the imaging, if you see this X-ray, you have significant swelling here, upper neck. Likewise, you have hypodensity here. Submental and submandibular also, sublingual also. That's a CT scan. We have done CBCT also, which shows detail about each and every tooth. The root of each and every tooth can be easily made out in CBCT, but not in a normal CT scan. So that we can manage if the source is from the tooth, we have to call the maxillofacial surgeon, if possible, with the same sitting, at the same time of operation. When we do decompression of the neck, we can call the maxillofacial surgeon. We can deal with the dental cause also. The surgery altogether, say around 1 hour. What we plan to do is 2 finger breadth below the mandible. There's a long incision, broad incision from one angle of the mandible to another angle to another one. The whole part will be opened up and we'll go in layer by layer, staying in midline, then go laterally. First we'll open the submaxillary space, do compression. We can see the fluid, edematous fluid coming out. Then we will enter the sublingual space. The whole space, all the 3 spaces have to be opened up, and we will not suture it up, and no drains too. This needs daily dressing at least for 5 days and is left for secondary healing. Soon after surgery, the patient will be in ICU, in isolation, followed by shifted to the ward where daily dressing, wound dressing will be going on along with IV antibiotics, analgesics, IV fluids. Antibiotics, 3rd generation cephalosporin, and a combination of medicines will be given. Even aminoglycosides will be added up. After 5th day, 6th day, when the fever has subsided, patient is able to breathe normally. The patient can move the neck normally without any pain. It's time for discharge. By the 5th or 7th day, the patient can be discharged. During discharge, we'll give a course of antibiotic to be continued, analgesics, painkiller if necessary for 2 days, along with multivitamins. Wound dressing to be done every alternate day or 3rd day. If there is a hospital nearby to the patient's home, they can get it done there. Preferably, it can be done in the same hospital by the surgeon who has done it. At home, the patient has to be ambulant. They can do all the normal things, work at home, eat at the right time, don't skip meals, avoid hot and spicy food and cold drinks. You can take shower but see that the neck part doesn't get wet, and all the normal activities will be going on. And the review will be after, with the discharges on the 7th day, the review will be after 3 or 4 days. So, I'm repeating, this is a ENT emergency. We have to rush to the hospital at the earliest so that we can save the patient. Thank you so much.